Pregnancy with renal disease. Letter of referral. Dear Dr. Mrs. Patricia Redwood, aged 30 years. Please would you see this woman who has just discovered that she is pregnant for a second time. She had what was thought to be preeclampsia at 34 weeks in her FTRST pregnancy 3 years ago and was induced at about 35 weeks. I am pleased to say that her baby boy is quite well. About 2 months ago we saw her for contraceptive advice because she was considering going back onto the oral contraceptive pill. Her blood pressure was 142/86 mmHg, CONF turned on repeated measurement. She had positive urinalysis for protein and her creatinine was slightly elevated at 122 moles/L. Following discussion she decided to continue to use barrier contraception and is now pregnant. I think she almost certainly has mild chronic kidney disease and would be grateful for your advice. Yours sincerely. NB. A creatinine outside the normal range is often dismissed as mildly elevated. Remember that it equates to loss of about 50% of normal glomerular filtration rate, GFR, for age and weight. Introduction. Preeclampsia is the most common medical complication of pregnancy, affecting 5 to 7% of previously healthy women. Pre-existing renal disease increases the risk of preeclampsia, and in women with preeclampsia it is easy to overlook evidence of pre-existing renal disease. Pregnancy in women with kidney disease may result in a worsening of renal function and is associated with increased fetal morbidity and mortality. When counseling women with renal impairment, one has to consider the risk to both the mother and the fetus/baby. Risk of maternal renal disease to the fetus. Almost 60% of infants born to women with a baseline serum creatinine greater than 125 moles/L are premature and they are usually small for gestational age. There is a progressive increase in the risk of prematurity and reduced size with more marked renal insufficiency. However, advances in neonatal intensive care have improved fetal outcomes so that the survival of babies is now routine, even when born as early as 27 weeks gestation. Chances of a successful pregnancy are around 65 to 85% if the pre-existing creatinine is below 175 moles/L and 20 to 30% if over 250 moles/L. Risks of pregnancy to the mother with renal disease. As a woman's degree of renal insufficiency increases, the risk that renal function will worsen during pregnancy rises sharply, a tendency exaggerated by the presence of hypertension. Broadly, among women with renal impairment, about 15% of those with a pre-existing serum creatinine less than 125 moles/L, about 40% of those with a pre-existing serum creatinine of 125 to 175 moles/L and about 65% of those with a pre-existing serum creatinine greater than 175 moles/L experience a decline in pregnancy. As many as 1 in 3 women in the latter group require dialysis during or shortly after pregnancy. Among women with moderate or severe renal disease, the deterioration in renal function is usually irreversible. History of the presenting problem. Was there any evidence of renal disease in the past, especially early in the course of her first pregnancy? BP and urinalysis would have been checked at the time of the first pregnancy. Significant proteinuria early in the pregnancy would prove that she had renal disease before she had preeclampsia. It is also important to ask directly whether she has ever had her urine or blood tested at any other times. If there were urinary abnormalities in the past, this would constitute strong evidence of underlying chronic renal disease. In contrast, if the urine had been tested and showed no blood or protein, this would be consistent with a more acute renal problem. Renal impairment of the degree described in this case is very unlikely to cause symptoms, but there may be clues that renal function is not normal, and an appropriate history may reveal clues as to what has caused renal damage. Ask the following. Do you have to get up at night to go to the toilet? This suggests lack of urinary concentrating ability and commonly occurs in people with renal impairment. Of course, it is also quite common in people with normal kidney function, and prominent nocturia in elderly men is much more likely to be related to the prostate. Did you have infections in your urine as a child? Did you have trouble with wetting the bed? Either could suggest reflux nephropathy. Have you ever passed blood in your urine? Episodes of macroscopic hematuria would suggest IgA nephropathy. Does anyone in your family have a kidney problem or high BP? This could suggest autosomal dominant polycystic kidney disease. Do you ever take medicines, herbal remedies, or painkillers? Interstitial nephritis or, much less likely, analgesic nephropathy are possibilities. Have you had any skin rashes, trouble with your joints or eye problems? These might suggest systemic lupus erythematosus, SLE, vasculitis, or interstitial nephritis. Have you had any other pregnancies? Spontaneous abortions might suggest an anticardiolipin antibody syndrome. Other relevant history. The patient's feelings about her pregnancy should be gently explored. However, if the conversation is led in this direction by the patient, or by the examiner, then it will be important to explain that at this level of kidney function the risks to the patient and the baby are slightly increased, that more intensive monitoring than usual will be recommended, but also that the likelihood of a successful outcome for the baby is very high. At this level of renal function, the pregnancy is unlikely to result in an acceleration in the course of kidney disease. Indeed, if the woman knows she wants more children in the future, then she needs to understand that kidney disease generally progresses over time, and that if her kidneys were worse the risks would be higher. Plan for investigation and management. Investigation. Investigation of the patient, not including standard renal and obstetric investigations that have already taken place, should include the following. Urine dipstick for hematuria, proteinuria, and glycosuria. Urine microscopy and culture for infection. Asymptomatic bacteriuria occurs in up to 7% of pregnancies. Spot urinary protein/creatinine ratio or albumin/creatinine ratio for quantification of proteinuria. Serum creatinine to estimate GFR. Remember, GFR normally increases and creatinine falls in pregnancy. Fig. 2. Baseline liver function tests, serum urate and lactate dehydrogenase. This patient is at increased risk of preeclampsia and hemolysis, elevated liver enzymes and low platelets. FBC and blood film, platelet count and evidence of hemolysis. Renal ultrasound. This might show scars, which would establish a diagnosis of reflux nephropathy, or cysts. The history may suggest other investigations, e.g. immunological tests if there is any suggestion of SLE or a systemic vasculitis. Note that renal biopsy can be performed safely in pregnancy if necessary. Investigation of the fetus, not including standard obstetric tests, should include close monitoring for intrauterine growth retardation with serial ultrasonography. Management. Management of known renal disease in pregnancy involves meticulous BP control, using drugs known to be safe in pregnancy. This will often require alteration of medication. Avoidance of salt. Low-dose aspirin. Heparin if there is a high risk of thrombosis, e.g. nephrotic syndrome. Antibiotic prophylaxis in those with recurrent urinary tract infections. Further discussion. Preeclampsia. Preeclampsia is more common in first pregnancy, when with a new partner and in multiple pregnancies. It is also more common in those with renal impairment. The definitive management of preeclampsia is delivery of the baby, and the balance to strike is between risk to the baby, prematurity and intrauterine death, and risk to the mother, convulsions and irreversible renal impairment. Reflux nephropathy. The incidence of vesicoureteric reflux is as high as 1 in 4 in the children of patients with reflux nephropathy. It is therefore recommended that children of a patient with reflux nephropathy should be screened for vesicoureteric reflux soon after birth, usually with a mixture rating cystogram. Pregnancy in patients on renal replacement therapy. Pregnancy is uncommon among dialysis-dependent patients. The likelihood of successful pregnancy is substantially higher if the patient becomes pregnant before needing dialysis than if she conceives while on maintenance dialysis. The management of the pregnant dialysis patient involves increasing both dialysis dose and frequency, minimizing cardiovascular instability and fluid shifts, and monitoring anticoagulation carefully. Careful monitoring of intrauterine growth is required. Renal transplantation restores fertility.